Hi, everyone. You can go ahead and pause your screen here if you'd like to just look at the poster, but I will go through some slides to carry you through this information in about 10 minutes. So I'm going to go ahead and move over to the other one. Okay. Yeah, so my name is McGinty Chilcutt. I'm a cardiology fellow at UNC Chapel Hill. And excited to present a case today of acute eosinophilic myocarditis after chemotherapy with daunorubicin. I want to present this as an example of anthracycline cardiotoxicity and how it fits into the current framework of thinking about this topic. So I'll begin with a little background, thinking about the traditional paradigm of anthracycline cardiotoxicity. So it's known, this was a known phenomenon since the late 60s, early 70s, that anthracyclines can cause a cardiomyopathy, arrhythmias, clinical CHF. And between the 80s and the early 2010s, classification was divided into three groups. It was either acute or chronic, and chronic was divided into early onset or late onset, depending on whenever the patient became symptomatic. So acute cardiac toxicity was generally defined as either during infusion of anthracycline or a few weeks afterwards. It was thought to be reversible. There's a lot of variable presentations within this category of acute cardiac toxicity. Now, chronic was a little bit more typical CHF symptoms because they had a physiology of dilated hypokinetic cardiomyopathy. If they presented with symptoms within 1 year, they were early onset, and greater than 1 year, they were late onset. Problem was they were usually irreversible by the time they had developed symptoms. They were refractory to heart failure medical therapy, and they had a poor prognosis. So there were problems with this paradigm. The definitions were vague. We didn't know the incidence and prognosis very well because it was based on retrospective data of childhood cancer survivors. We were only looking at EF after patients had developed symptoms. We weren't detecting any subclinical disease, and it was leading to the assumption that there were three separate entities. And the guidelines were generic. We didn't have any direction for early screening to try to detect this before it became symptomatic. Often we were diagnosing very late and at a point where the disease had become irreversible. But then in 2015, there was this first prospective longitudinal evaluation of EF in patients getting anthracyclines. It was about 2,600 patients. They were getting regular assessments by echocardiogram for greater than 5 years. And they defined cardiotoxicity as a 10% decline and an EF less than 50%. So there was about 9% of patients that met this criteria. There was dose dependency, and the good thing was they were detecting with minimal symptoms. So they were getting detection pretty early. 81% had only NYHA to 1 to 2, but there were a few patients, 9 in particular, that were hospitalized, and 6 of those patients died. Interestingly, a majority of those patients, 98%, developed EF reduction that met cardiotoxicity criteria within 1 year, compared to previously where we thought many of these patients were actually presenting as a late onset chronic condition. And then furthermore, on the right-hand side, you can see that they detected reversibility to their EF decline. 82% had either full or partial reversibility or recovery of EF. They started enalapril or enalapril and a beta blocker and had pretty good recovery. So the same year, there was an editorial published which showed that perhaps 3 separate entities was incorrect, and rather anthracycline cardiotoxicity fell upon a spectrum, a clinical continuum that went from cell injury all the way to progressive LVEF decline, and if untreated or unrecognized, it might lead to irreversible CHF that was identified in these historical retrospective studies. So ultimately, this made its way into the guidelines, and several societies here had commented on this phenomenon and made some recommendations trying to answer these questions, trying to figure out who is at elevated risk for cardiac dysfunction, how can we modify those risk factors, how can we modify the chemotherapy dose to reduce the risk of LD dysfunction, and then importantly here is trying to determine what are the screening options during and after cancer treatment to identify these patients before they become symptomatic. So ultimately, there has not been a clear recommendation screening interval, but there's a general consideration that we should be thinking about doing echo, MRI, longitudinal strain, and biomarkers for surveillance to look for this. Some of the issues are we don't have a great standardized definition of cardiotoxicity by echo or by strain imaging. And so there's some gaps. And one of the particular gaps I wanted to talk about is the fact that there's no specific recognition of acute and subacute toxicities or their management, and including myocarditis. So I wanted to talk about this case. So it's a 49-year-old guy who presented to the clinic ultimately with fatigue, weight loss, dyspnea, found to have AML by a bone marrow biopsy. He received induction chemotherapy with daunorubicin on days 1, 2, and 3, and then 1 to 7 he got cytarabine. This is a 7+3 protocol, and he had a good response. His day 28 marrow, he had recovery of his trilineage hematopoiesis and only 3% blasts, and he basically had achieved complete remission. 1 month later, he came back to the ED. He was having exertional dyspnea and chest pain. He had entered cell count recovery, which was expected. He had a white count of 28,000. But interestingly, though, he had an eosinophil count of 1,300, which increased to a peak of 2,800. Troponin also rose from 2.3 up to a peak of 7.3, and a similar increase in pro-BNP as well. This was his pre-chemotherapy peristernal long axis, which is a normally functioning ventricle. And then when he came into the ED, we did this echo, which showed just marked infiltration of the myocardium, including the RV free wall, the septum, the LV. He's got a pericardial effusion. And then here's some short axis images. This is pre-chemotherapy, largely unremarkable, and post-chemotherapy, just diffuse infiltration of the LV and RV. So ultimately, we did an MRI, which showed a little bit more of the same diffuse infiltrated process involving the LV and almost the entire RV. And then also the MRI showed late gadolinium enhancement of the RV free wall and the RV side of the septum with patchy infiltration of the LV. And there was concern based on this imaging that he might have leukemic infiltrate. So we did a biopsy which showed interstitial infiltrated inflammatory cells. And ultimately, there was a population of eosinophils, which was interesting. And then these larger mononuclear cells that was concerning for either leukemic infiltrate or macrophages. So these are CD68 stain showing that it's likely macrophages, a negative CD117 stain showing that it's probably not blasts. His blasts were known to be 117 positive, and then CD34 showing absence of blasts. He does have normal staining CD34 of his endothelial cells in his myocardium. So ultimately was diagnosed with an eosinophilic myocarditis without definitive evidence of AML infiltration. Because of this, we treated with steroids. Got Solumendrall 1 gram IV daily for 3 days, and he had a very rapid decline in his troponin, which was also reflected in his pro-BNP and his eosinophils, which declined to a nadir of 200 cells per microliter. And again, as a reminder, this was his post-chemotherapy long axis. We did just a few days after the steroids, repeated an echo, and he had marked improvement in the thickness of his LV, his RV free wall, and even his pericardial effusion had improved with the steroids. And this was actually demonstrated to maintain normalcy on 1 month after steroids without any additional treatment. Here's his short axis. So ultimately, I wanted to discuss acute cardiotoxicities of anthracyclines, including myocarditis. It's interesting, this has been reported for decades, but the incidence is not well described, and there's just not a lot of features that have been looked at. There's many case reports. Here's a couple that are interesting. Chronic myocarditis presenting as diffuse myocardial calcification, anthracycline myocarditis, and VF arrest. A patient who had anthracycline-induced cardiomyopathy, but also HHV6 myocarditis. Here's another case after induction therapy with idarubicin and atra. So there's multiple case reports. There's also in review articles, discussing the incidence of this. Usually it's very vague. So even back in the 70s, it was recognized that this could affect patients with a very high mortality rate. 20 years later, it was documented that it's very rare, but no definite number. It's very rare compared to the more common chronic toxicity. 2007, probably getting closer to the truth here, where it says myopericarditis is part of a heterogeneous family of toxicities. And they proposed that if the initial acute damage was only mild to moderate, then the process of myocardial remodeling over time might ultimately lead to this chronic presentation, which is kind of an interesting thought. And there's some histologic data to support that I'll show in a second. But in 2010, someone had reported that acute toxicity incidence was at 11%, but seems pretty high. This includes all forms, though, of acute toxicity, including myocarditis, but also palpitations due to sinus tach, PACs, PVCs, other arrhythmias that are thought to be maybe more so due to sort of myocardial edema at the time of infusion. So this is from that 2007 review that just lists the incidence of myocarditis as infrequent. I mean, just to give you an idea of like how little this has been studied. And this is one paper looking at the histology of myocarditis. They took 11 patients with known doxorubicin cardiotoxicity. And interestingly, 4 of those biopsies showed myocarditis, and then 2 additional were showing borderline criteria for myocarditis. It was usually a T cell population with areas of replacement fibrosis that suggested there might be 2 things going on, an area of mild myocarditis plus an area of chronic replacement fibrosis. And they quote from their paper, this suggests that myocarditis might be a component of a doxorubicin-induced myocardial injury. Additionally, there's been lots of studies to look at the cellular and molecular mechanisms. Initially, was thought to be mediated primarily by oxidative stress, leading to DNA damage. And in 2014, the mediator for that was found to be topoisomerase 2 beta, which anthracycline inhibits that enzyme from doing its normal job of uncoiling DNA filaments, leading to mitochondrial dysfunction and activating cell death pathways. So. And then furthermore, different types of cells are affected. So cardiac myocytes, progenitor cells, endothelium, and fibroblasts. So in summary, I think it's nice to see how this case fits into the overall picture of the topic. So anthracycline cardiotoxicity has multiple mechanisms, molecular and cellular, that lead to heterogeneous presentations. It's likely a continuum rather than multiple distinct entities. It turns out that the EF decline occurs roughly 9–10% of patients, usually within the first year of therapy, and appears to be reversible if you treat it early. The guidelines at this point don't have terribly prescriptive protocols for screening, but says that screening is reasonable with echo biomarkers strain for early detection. Now, what's left out of the guidelines, of course, is the myocarditis. So it's rare, but it's an important form of cardiotoxicity that is reversible with prompt recognition and treatment. And we need additional studies to determine its epidemiology, its natural history, what is the prognosis, what is the pathophysiology, and what is a treatment? And do we need to be preventing this? Do we need to be prophylaxing against this if this is ultimately one of the mediators of a chronic LVEF decline? And then ultimately, do we need to use this data to determine how can acute and subacute toxicities be incorporated into the clinical practice guidelines? So it's just a very interesting case that I thought was excited to share some information about how it fits into the overall topic, the anthracycline cardiotoxicity. Here's my references, 2 pages, and just be happy to answer any questions, and I'll be monitoring the chat and email. So thank you for listening.